And then, I always learned in neurology residency that the word dizziness should not make it past your chief complaint. Like, it is our job as neurologists to determine what people mean by dizziness, right? So we're kind of programmed not to use that word, okay? So you have to kind of drag out from people or try to help them to communicate to you what it is that they're experiencing. Does anybody have any examples of vertigo that aren't covered by these kinds of explanations? I just put together a list of things. So non-vestibular dizziness, so sensitivity to visual surroundings is a type of dizziness. And it also is, I think, a lot cultural. People talk about dizziness in different ways, different cultures do. A feeling of imbalance or tilt. I get that a lot. People say they feel like they're veering to the left or that kind of thing. The sensation of impending fainting or presyncope, like that feeling you get when you stand up too quickly. We get a lot of consults on that topic. Sometimes people just mean cognitive fuzziness. Okay, so feeling kind of unclear, confused even. Detachment from themselves or their surroundings, so like a depersonalization, and they might use the word dizzy to describe that kind of a feeling. And then just like not feeling well, like, so they use the word dizzy, but maybe these things have kind of different approaches. Okay.
My mother was a very simple woman, and she had a hard time explaining herself, but whenever she didn't feel well, it was so hard to determine what she meant because she always used the word woozy for everything. Right.
And what does that mean? I don't know. I mean, it means different things to different people. So like I said, I think, neurologists, we often have the luxury of spending more time with people and trying to kind of, and sometimes people have several of these things. Like they'll have the room spinning sensation, they'll have the visual sensitivity, they'll have, so they're not independent of each other. Okay, so as mentioned before, vertigo and migraine are both common conditions. They're commonly seen and evaluated in different healthcare settings, whether that's primary care, neurology, ENT, physical therapy, primary care, etc. There does seem, however, to be an association between migraine and vertigo that is higher than chance based on those two common conditions. So, there's all this question of pathophysiology and do they share like a common pathway? I don't know. So again, patients with recurrent vertigo are more likely to have migraine and vice versa. Kids who have vertigo are more likely to go on to develop migraine as adults. Kids who have motion sickness are more likely to, and motion sickness to me is it's a type of vertigo, right? So this motion is, you're perceiving it as something that's making you sick or ill, and so that so there's some convergence there of those two disorders. And then, I think there's more and more interest of helping people understand and treat these symptoms. And is there an all-encompassing term, and what should it be? So migraine-associated dizziness, migraine-related vestibulopathy, migraine as vertigo, benign recurrent vertigo, vestibular migraine. So I don't know that I use any of these. Susan? I mean, benign recurrent vertigo in a patient who has migraine, I might say something like that. But, in vestibular migraine, we're gonna go through the ICHD criteria for that. It'll be real we are gonna go through a little bit of criteria just to see if that's actually a helpful way to talk about that.
I think the one thing too, Alyssa, that comes up oftentimes in clinic visits are people who describe this disembarkment syndrome, which is not clearly vertiginous.
Yeah.
They feel like they just got off the boat, right? They just can't
get
their grip.
Yeah.
And so then with that then comes the nausea, and then they want to, everything else comes with that. So that's always like not clearly distinct, but certainly follows with it.
Yeah.
So
I always think of that.
Like headache soup. sometimes.
Yes, exactly. And so this idea of an all-encompassing term, I don't think there is one, because I don't think it's all. I think it's related.
It's a sensitive brain of migraine, that's the problem.
Yeah.
It's not easily defined sometimes.
Right, and then you're sensitive to these sensory inputs, right? Including motion. So yeah. Okay, so obviously you guys all know about, migraine, a chronic condition, episodic manifestations. Mainly, so, there is a genetic component, but it's just very common in general, with 16% of people in the world having migraine, 30% of women having migraine on a regular basis, 50% of women having had a migraine, okay? And then there are a plethora of environmental triggers, and then basically you have episodic or chronic migraine more than or less than 14 days per month. But I wanted to just kind of refresh everybody's memory, or maybe this is new to everybody, because I want to talk about vestibular migraine versus migraine with aura, right? Okay, so migraine is a generally one-sided, but not always, throbbing, pulsating, moderate to severe, long-duration headache, 4 to 72 hours, associated with either nausea or vomiting or sensitivity to light and sound. 5 attacks of, there you go, got migraine. Okay. And then, aggravated by routine physical activity. And then, so migraine with aura, so about 25% of people who have migraine, 25% of people who have migraine have an aura. So an aura is a reversible neurologic symptom related to headache, okay? And you have to have 2 attacks lasting from 5 to 60 minutes, although we certainly see auras last longer, of reversible visual phenomena, sensory phenomena, or speech disturbance. And all of those are kind of your run-of-the-mill typical auras. And some patients have one, some patients have all 3, some patients have one kind of aura with 1 attack and then may experience a different kind of aura in their lifetime. Okay? So then specifically at the bottom of this diagnostic criteria, it says no motor, brainstem, or retinal symptoms. So the distinction between a migraine with visual aura and a retinal phenomena is unilateral. So migraine with aura, you're going to have that visual phenomena present on uncover both eyes, retinal, one eye. Motor, so you can have the numb, you can have the speech, you can have the visual, but if you're weak, that's a complicated migraine aura, okay? Just changes the way we treat that a little bit. And then a brainstem aura, okay? So migraine with brainstem aura used to be called a basilar artery migraine, basilar migraine, basilar type migraine, kind of alluding to the blood supply to the back part of the brain. Okay, but we changed the name because that old name implied a vascular component that may or may not be there. Okay, so now we're calling it migraine with brainstem aura, and I wanted to talk about this specifically because vertigo is one of the defining characteristics here. Okay, so room spinning sensation, head spinning sensation, sensation of motion when motion is not taking place, not just dizzy. Okay, distinction there. But in addition to that, you have to have something else pointing you to the posterior circulation. Okay, so vertigo alone is not enough to do this. So you have to have dysarthria, tinnitus, diplopia, ataxia. If a patient comes in and they have tinnitus and vertigo, do I call that migraine with brainstem aura? No. Do you? I have to be a little bit more compelled than that.
It's a bigger story.
It's a bigger story. It's a bigger, badder headache. And again, we treat it a little bit differently, avoiding triptans. But, so again, I have to be a little bit more convinced than just vertigo with tinnitus. If I have vertigo with altered level of consciousness, vertigo with clear double vision, so I feel like this diagnosis is more rare than a migraine patient with vertigo. But that's the diagnostic criteria for that. And then how is that different from vestibular migraine? Okay, so So this is sort of a newer entity, and it actually first appeared in the ICHD-3 published in the appendix in January of 2018. I think it's interesting that it's relegated to the appendix because and I always talk about the big picture diagnosis is migraine. So you start with that, and you make the diagnosis of migraine with or without aura, and then you can tack on the vestibular migraine if you so wish. But really, the overwhelming diagnosis is migraine with aura. So a lot of times it doesn't end up changing the way I treat the patient, which is, maybe I send them to vestibular therapy, but I'm going to work on treating the migraine regardless. I might be more inclined to treat with a certain drug. But it's not a standalone diagnosis from a headache perspective. Okay, so comorbid with anxiety, as is migraine. So more than 50% of patients who have vestibular migraine also have anxiety. ENT and the vestibular people, they do a lot of testing. And I think sometimes it's good for excluding other causes of vertigo, but doesn't help me rule it in or out. I mean, if there's something else clearly going on, that's easy enough. But if a lot of times the results of that are either normal, inconsistent, or difficult to interpret. And again, I mean, it could just be between attacks. You're capturing this patient when they aren't having, there are a lot of different factors there. Biopsychosocial approach to treatment is best for vestibular therapy, which is addressing anxiety, treating migraine, possible vestibular therapy on top of that. And then vestibular migraine might be a trigger and or a perpetuating factor to persistent perceptual postural dizziness, which I'm going to touch on a little bit in a minute. Okay. So vestibular migraine diagnosis. So both the International Headache Society and the International Classification of Vestibular Disorders looked at this diagnostic criteria and then published it in January of 2018 with the ICHD version 3. This is again in the appendix, and you want to have 5 episodes fulfilling the criteria, the first of which is either a current or a past history of migraine with or without aura. Okay, so again, that's the main diagnosis, and as we know, there's no cure for migraine, so a patient who has had migraine in the past still has a sensitive migraine brain. Okay, so then the next, C, vestibular symptoms of moderate or severe intensity lasting between 5 minutes and 72 hours. I think there was a lot of kind of consternation about that time frame because I think we see patients who have vertigo that it's much longer lasting than that criteria. And then at least half of the episodes are associated with one of the following migraine features. So, headache, okay? Unilateral, pulsating, throbbing, moderate to severe, aggravated by routine physical activity. You'll recognize that criteria from the migraine criteria. They have to have photophobia and phonophobia or a visual aura with half of their vertigo attacks, okay? So in theory, you could have a patient who has a history of migraine with aura, who has 5 episodes of vertigo with sensitivity to light and sound and the visual symptoms without the headache. And that would meet criteria for vestibular migraine. But you're also going to diagnose typical aura without headache and history of episodic migraine with aura. Okay? So that just how we approach that kind of diagnosis. Okay. And then it's interesting to me, the International Headache Society did not put in a category of probable vestibular migraine, but the International Vestibular Disorder Society did in their criteria. And here, they're saying you only have to have one of the criteria be through, you do not have to have a history of migraine. and you don't have to have a headache. And that's where I'm like, do I think that's migraine phenomena? No. So I would never, does that make sense? So with their criteria here, they're saying you do not have to have a history of migraine and you do not have to have a headache, but your vertigo can still be considered probable vestibular migraine. How do you feel about that, Susan?
I think that comes in the realm where people don't meet the criteria for Meniere's.
Yeah.
And so I think this is where the squeakiness between neurology and ENT disciplines collide in the Venn diagram. And this is like that sweet spot in the center.
Yeah.
Where it feels a little bit like migraine. It's not quite Meniere's. There's something going on.
Yeah.
So maybe it's this.
Yeah.
And sometimes too, I think when you pick out the history in the patient, we learn like maybe there's a little more migraine in the family.
Yeah.
And then maybe there's something else in the underpinning of their history
Mm-hmm.
that wouldn't otherwise give that illusion of that until there's more story being told.
Right.
People also tend, in some instances, not to disclose all headaches initially.
Yeah.
And I find that that's really telling in the story of, you know, when they come back and they're like, oh, well, you know, 20 headaches in the last 90 days if we do a MIDAS. So you've had 70 days of no headache in the last 90 days.
Right.
Oh, no, I still have a headache every day.
Yeah.
I've only had 20 migraine days. And so
Right.
I think really in, you know, the expression of how questions are asked of a patient is how we really gain more knowledge about what else is being asked and told.
Yeah.
And I think sometimes as we've learned over the years of asking patients about their history, or in other instances when they've been seen by non-headache specialists, there is this stigma about they don't want to know about their headaches, so they tend not to tell about their headaches. Whereas we just give it to me. I want to know everything.
Every headache.
And so like,
all comers.
you know, and so I
Yes.
think that's the difference. Is
Yeah.
sometimes trying to get that history is tougher to pull out of people. Believe it or not. But I think that's what I come up against, and so that's maybe where this fits.
Yeah.
That's my long answer to a short question.
No, I think that's good. And, you know, that's why I will always see, like, I'm a headache subspecialist, and I try to, not that I just see headache, but I will see every vertigo patient that comes across my referrals, because I'm like, you know,
It's in there.
It's probably in there. And if it's not, it's not. But I think it just makes sense to try to get that history from people so that you can help them in the best way possible. And there are some overlap drugs there too that make a lot of sense. Okay. So persistent postural perceptual dizziness. I don't know, I kind of like the old name better, which is chronic subjective dizziness. So sort of some vague symptoms. Patients feel dizzy most of the time for at least 3 months. And, you know, so fluctuating dizziness, unsteadiness that occurs every day for at least 3 months. I have a little Mayo Clinic patient handout that I think is helpful for patients, because, you know, it talks about provoking factors and things that probably seem a little bit crazy, like you don't want to go into a crowded store, or the patterns on the floor bother you, or traffic bothers you, or things that feel like, okay, I'm like losing it a little bit, but these things are bothersome to me. And it's like, well, it's not just you. And so I like this diagnosis, because sometimes if we can't classify or categorize a patient's symptoms, they don't fit neatly into those diagnostic categories, maybe this will help them understand it a little bit.
Do they sometimes do something to rule it out as simply as, I was spacing on the name of the medication for the dizziness that's, what is it?
The meclizine, or?
What's that? The medication is just for basic dizziness?
Yeah, Antivert.
Antivert, yeah.
So I don't love that medicine. I think there are better ways to treat benign paroxysmal positional vertigo. But yeah.
I mean, just sometimes just rule that form out.
By trying that medicine?
I mean, no, not necessarily by that medication, but however you rule it out. I mean, is there a way just to rule that out?
Well, that's the thing. A lot of it, you image people. You know, you think about posterior circulation, you think about brainstem, you think about cerebellum, you think about blood flow to those areas, and neurologists always think about, well, what's the worst possible thing this could be, right? And so we look at those things, and then we have them get their ears checked, and they get this diagnostic testing, and then you're left with no structural lesion, no vascular, you know, and then it becomes more of a clinical diagnosis. So once you've excluded things, then, you know, it's a little bit harder to rule things in or out entirely. And really, I think what people just want to do is feel better, right? And they want to, I think, have a better understanding of what's going on. Okay, so let's see. So I find that patients can have chronic subjective dizziness and episodic vertigo and migraine. So here they're saying does not include vertigo, although I think these patients can also have that as a separate diagnosis. So the treatment I like a lot is venlafaxine. So SNRI, only kind of modernly used antidepressant, anti-anxiety medicine, where those things are comorbid with both vertigo and migraine. The only one that's independently helpful for migraine, helpful for chronic subjective dizziness. So I like that medicine. And so if somebody comes to see me and they're dizzy, that's kind of one that I'll try. And I'll try the SSRIs as well, but the venlafaxine is going to give you the most bang for your buck, because how much of this is migraine associated? How much of this is chronic subjective dizziness? How much of this is anxiety driven? And then all of those things. And so I think venlafaxine is a nice kind of way to go for these patients. And then the physical therapy with the habituation, which is what you were talking about, moving your head certain ways. And exposure therapy, I don't know what that means. You put a patient on a tilt-a-whirl, and I don't know. But
what's that medication you were mentioning, and does it have another name?
Venlafaxine, Effexor.
That's what I thought.
Yeah.
Yeah.
Do you use that a lot?
I mean, yeah, it's part of the 2012 AAN guidelines for treatment of migraine as well. So
Yeah.
some approval, sometimes duloxetine.
Uh-huh.
Tolerate Effexor.
Yeah. I mainly run into nausea.
I mean, they both have it.
Yeah. So, so I wanted to put this together, one for the APCs we're training, and then two, just to kind of revisit the way that I think about vertigo and migraine and how I talk to patients about it. So I don't know with the publication of this vestibular migraine criteria if I'm going to change what I'm doing. But I don't know. What do you guys think? Do you think it's helpful to have that kind of conversation with doctors about, well, your symptoms meet criteria for this or that? Or is it more helpful to say, patients with migraine have vertigo, and here's what we're going to do to best manage your symptoms? And another question, has anyone had a lot of success with treatment for vertigo, and what have you done that has been effective?
Well, I have, every once in a while I have vertigo, and I have chronic headaches, actually. I have hypnic.
Okay.
And I have them practically every day, but they're getting better thanks to Dr. Henry.
Oh, good.
And I haven't really put it together, the vertigo with the headaches, because the vertigo doesn't happen very often at all.
Yeah.
So it was my internist who I discussed it with, and she said, well, yeah, you had vertigo, and take Bonine for it, Dramamine.
Oh, okay. Uh-huh. Yeah.
So I don't know if that, so I had an episode just the other day. And
Yeah.
They don't come very often, so I don't feel like I need to be on a daily medication.
Right, or do something like therapy
But
for
I
it.
haven't really connected them with my hypnic.
Yeah, and it's interesting because, hypnic headache is just a much less common headache that we know less about because it is less common. But I think there's probably, if we really delved into it, I think we would find an association between vertigo and a lot of primary headache disorders, not just migraine. But again, they're both very just common in general, so. Is there a causal relationship? Is there an association
When I
with
get
hypnic headache?
vertigo, I can't, it'll hit me, and it
Yeah.
hits me fast, and nothing spins. I keep reading about it, and they say when the room's spinning, no, the room doesn't spin. I just stand up and I have no it's like my balance is completely gone.
Right.
I grab onto things and I have to sit back down and.
And if you answer no to room spinning or head spinning, someone will say, oh, well, you don't have vertigo, right?
Yeah.
But they're missing, yeah,
Nothing spins.
yeah.
I just can't walk. I'm like this.
Yeah.
So do you think that I should take the Dramamine or Bonine or whatever?
I think for like a short period of time where you're symptomatic like that, yes.
Okay.
But I think if patients are chronically or persistently dizzy, I don't love meclizine in that scenario. I think, like I said, I think it's better to sort of do what you can to retrain that communication as opposed to taking that medicine just over and over again.
It's more exposure and habituation.
Yeah. I think also the older people get, the crappier their vestibular system is. So people are more sensitive to things like
The
that.
crappier their what is?
Vestibular system.
Oh.
Like, you know, you used to be able to go on roller coasters or on a swing or, you know, and now I can't even look at anything that's spinny like this. So I think there's just some other factors there.
I've never been able to do any of that stuff. I was the one that got car sick as a child.
Mm-hmm.
And when I was walking on the sidewalk with friends, or I'd always end up walking to the left.
Yeah.
On the sidewalk, pushing my friends off the sidewalk, never to the right, but I'd always kind of gradually, pretty soon my friends would be off the sidewalk on the left.
Yeah, and I'm glad they, where did they, yeah, the feeling of imbalance or tilt. Sort of not clearly vestibular, but I think vestibular.
Yeah, I didn't feel imbalanced.
Just
I just kinda
tilt.
walked that
Yeah,
way.
you
I just-
veer or you, I hear that a lot.
Yeah,
Mhm. Yeah,
I just wouldn't stay on my side of the sidewalk.
yeah. All right, so how much time do we have? Does anybody have, any questions about general headache things? It doesn't have to be about vertigo. Kind of open it up if anybody. Do you guys come here regularly, or it's like a first time for everybody? Regularly? First time.
Just from time to time.
Okay.
Yeah, if I see something that I'm like, that's me.
Interested in? Yeah.
So when I heard this, I thought,
Yeah.
probably need to know something about it.
You know, I used to drink coffee.
Uh-huh.
I mean, this is green tea, but I used to drink coffee, I mean, for many, many, many years. And then now I can't even stand the smell of it. It's just, and it's just like, coffee makes me nauseated, and I think it probably could trigger a headache too. I mean, just makes me feel totally awful. And I think it could be an RNA thing for headaches. But I'm not
The smell of
really-
it?
Yeah. Yeah.
Yeah, could be. Caffeine is usually problematic in its withdrawal. So it's like helpful as you're consuming it. And then the further removed you get from that caffeine source, the more likely you are to get a headache. So caffeine's a brain stimulant, and brain stimulants always increase your susceptibility to migraine. So yeah, it's hard to say. Maybe it's just your experience with caffeine that's with the coffee smell. Yeah. I never tell people no caffeine. Maybe I'm I'm like, small quantities consistently or none at all.
It's in our headache plan. I'm not a hypocrite, so I remember.
Yeah, yeah,
I'm sort of like 12 ounces a day.
yeah.
Not a
Let-
porta potty a day.
Let's be
Those
reasonable.
128 ounce jugs from Maverick, I'm not a fan.
No, or the energy drinks that have an obscene amount of
Everybody
it.
wants a cup of coffee.
Yeah, yeah.
So
So I try to be reasonable about it. If people aren't sleeping well, I tell them things like no caffeine after noon. And then you obviously always want to ask about other things that contain, like any over-the-counter weight loss product, any sort of over-the-counter energy thing, you know, and then obviously Excedrin, things like that, that are like kind of hidden caffeine culprits.
Like green tea lattes.
Green tea has a lot of caffeine in it.
does?
Can. Oh, yes. In fact, might be
Just
more.
caught my bubble.
I know. No, yeah, green tea. Some herbal teas are not caffeinated, but green tea can be very caffeinated. Yeah.
Okay.
Did you have a comment?
How do you differentiate between a migraine headache if you're suffering from migraine over a long time and a normal headache?
Well, so headache is just kind of the general category, okay? And then there are like there are primary headaches, which is kind of a headache for no other reason than you have a headache, of which migraine is one. And then a secondary headache, which is headache due to something else. So, you know, we always want to make sure we're not missing a headache due to something else. And then, like I talked about, if you have headaches that are one-sided, or they can be on both sides of the head, people always recognize this as a headache. I think they're less likely to recognize this as a headache, okay? So migraine, like we talked about, throbbing, pulsating, moderate to severe, debilitating, aggravated by routine physical activity. You want to like hide in a dark room because lights are bothering you, sounds are bothering you, you're nauseous, and that headache lasts from 4 to 72 hours. And then it's a pattern. So to meet that classification criteria, you want to have 5 attacks of that. So, you know, most people, so over 70% of people have had a tension type headache. It's pretty ubiquitous to the human experience. And most patients won't see a doctor about that. So that's the other thing. Like, I'm very like quick to be like, this is migraine, even when other doctors have said, I don't think this is migraine. Because sometimes what happens is what you have picked up in frequency, you've lost in severity and or associated features. Right? Or you just have to kind of pull that history out of people. So, yeah. So, again, you know, it's a common thing, 16% of people in the world. So, you know, you might have migraine if your headaches act like that. And then I think a lot of times people who don't have auras are less inclined to call a headache a migraine. Right? So, but that's actually less common than having a migraine without an aura. Yes.
I don't think it's just patients who are less inclined to call patients without an aura.
Yeah, oh, 100%.
I think we have to be thoughtful about where patients sometimes don't get the diagnosis from their experience in primary care, other
Yeah.
care providers.
Mhm.
So sometimes they go down a path. I think this is where I would say I have total gender bias, and that's where men don't get the diagnosis. And
Yeah.
oftentimes when I'm seeing patients and I say, if you have young sons, please be aware that if they're the kids that are barking in the car, they're the ones who play soccer and then they come home and they have a headache,
Yeah.
that's your kid is going to have a migraine. So
Yeah.
don't let them be told they have tension headaches when they grow up.
Yeah.
Like, pay attention, because yes, typically, as you articulated easily this in the early part of your talk, that this is typically a woman's diagnosis.
Yeah.
But definitely men get the under radar,
Yeah.
not diagnosed problem. And this is a very disabling diagnosis that
Yeah.
because of that gets misrepresented oftentimes as well.
Yeah, and while I am hesitated to call things probable vestibular migraine, I would call things probable migraine all day. I think everything's a migraine. That's my bias. And I think by the time patients end up seeing me, you know, and they've tried X, Y, and Z for their tension type headaches or for their neck pain or for their, right? And then I'm going, yeah, let's try this. Let's change directions. Yeah.
How often do you see chronic daily protracted headache? Like what percentage?
It's my bread and butter.
Yeah.
Yeah.
So what in your experience those help the most?
Well, so Chronic daily headache, so persistent headache occurring more days than not for at least 3 months. So obviously you always want to think about, secondary causes, right? So, and then, what's reasonable to look for. And I always, I think there is a reason why you're having headaches like that, but it's just a matter of whether or not we can identify that reason, right? And I always say to people, it's always good news when you don't have a reason to have a headache, because reasons can be things like a big Goomba in your brain or something like that, right? So sometimes, headache patients are disappointed that you're not finding a cause. And I can understand that, because there must be something going wrong there, right? So yeah, so you always want to make sure there's nothing else going on. And then there are basically 4 types of long duration chronic daily headache. So you've got chronic migraine, which we've been talking about. So someone who has a history of having episodic migraine goes on to develop headaches more often than not in a month, 8 of which meet criteria for migraine. I also don't get too crazy about that 8 of which meeting criteria for migraine. But you've got chronic tension type headache. You've got hemicrania continua, which is a little bit different type of headache. It's trigeminally mediated, and it's half your head hurts all of the time. And then you have some autonomic symptoms, so like redness of the eye, tearing of the eye, drooping of the eye, feeling like you have something in your eye. And then new daily persistent headache, which is someone who doesn't have a headache history, all of a sudden, one day, gets a headache, and it doesn't go away for at least 3 months. And those patients, it's always a really interesting, and they can often tell you the date. And so that headache can have either tension type headaches or migraine features. And I think, so even though I see patients all the time with chronic daily headache, I also see patients who have tried everything, or think they have, and then who actually have, and then patients who literally have been given nothing. So I think it just, I always consider it my job to come up with options, and sometimes I have to dig deep, but I think, patients, there's not one treatment for every patient, there's not one treatment for every headache, and sometimes it's a little bit of trial and error, and sometimes it's a little bit of putting up with some side effects in the interest of feeling better, but also we don't want to give you a medicine that has side effects that are worse than the thing that we're treating, so I think it's a little bit of patience. It's sometimes combining treatments. It's sometimes combining, medications with procedure-based treatments with, So there's not an easy answer to that, but it's not, and to primary care's credit, they're seeing 20, 25 patients a day, and they don't have a lot of time to kind of sort out, this more complicated history, and then don't really have the tools to say, okay, well, this is what you're going to take for prevention, and this is what you're going to take for acute treatment, and this is what you're going to take for, So it's a little bit, and then what is the patient willing to do? Because there are a lot of things that patients can do to, to kind of facilitate, right? Like, so, regular exercise, not skipping meals, staying well hydrated, avoiding triggers, avoiding, so it's medicine, it's maybe some psychotherapy, it's maybe some physical therapy, it's maybe some injections, and then there's prevention, so it gets a little complicated. And so it's some work on the patient's part, and then kind of checking back in with your doctor on a regular basis. And I think that's probably one of the biggest, aside from not doing anything, one of the biggest mistakes I see is someone doing something politely, one thing at a time, and going, well, maybe it'll work in the next 6 months, right? You really have to maybe that helped a little bit, and you have to add something else, and so you have to keep pushing. And so I usually see patients every 3 months or so initially, because most things take about 3 months to start to work for people, and then space visits out as people are doing better. And then, next thing you know, you haven't seen a patient in a year and a half, and I always think of that as a good thing, because it means they're doing better, typically, but not always.
What are some of the lengths of time that you see the persistent daily headache persist after sudden onset? And then what are some of the best treatments that you've seen?
So with new daily persistent headache, But I'm a little bit biased because my patient population is, they've seen primary care and they've been to the ER, and I tend to see the most refractory of refractory patients. So new daily persistent headache, you treat the way the headache behaves. So whether you treat tension type headache or whether you treat migraine. And I would say, even though that headache can occur abruptly, I think it is unusual for it to resolve and no more headaches. I think the expectation to set is gradual improvement over months, to have some headache-free moments, to have some headache-free days, and then finally to reverse the dynamic of that the headache day is the rule as opposed to the headache day being the exception. So instead of having headaches all the time, you mostly don't, and then you have a few. So I don't think there's going to be like a dramatic cure moment per se. I think even though that headache has a pretty dramatic onset.
What's the longest you've seen a patient have from sudden onset?
I mean, I think that could happen years, yeah. But again, it's a matter of getting the right treatment, getting the right, doctor, getting on the right treatment plan, and then acting on that information to try to get people to feel better. I think that's not to say there's no improvement in that time frame. If we can take a patient's daily head pain from a 7 to a 3, you've accomplished something. From completely unmanageable and unbearable to, still there but able to function. You haven't cured the headache, right? But you've made a lot of headway.
I'll take it over, but how much have you seen there be a physiological, what am I trying to say?
Cause.
Malformation or cause associated with that kind of headache? Do you ever see that?
Yeah,
Do you?
absolutely.
Like what, Chiari or something like that?
Again, you really want to, so you get the history, you get the picture of the headache, you think about what else could be causing this, and then you do the appropriate diagnostic workup. So, you look for those things, and, sometimes that's, structural, sometimes it's, due to intracranial hypotension or intracranial, so too low of pressure, too high of pressure, maybe, so there are different factors there. Like I said, I think, there are some things that are very clearly causing people's headaches, like, you get the patient with a retroorbital tumor and this kind of pain, but those patients are not the typical patient. The typical patient I see as a patient, like my patient today came in and literally had an MRI without contrast, 2 MRIs with and without contrast, an MRA of the brain, a CT angiogram, within an 18-month. So is it likely that I'm going to come in and find some magical thing that I'm going to fix and make their headaches better? It's not terribly likely. But that's our job, is to look for those things. And I think one of the most important parts of our job is that we don't miss those secondary headaches. But like I said, I think there always is some sort of cause, right? It's just, are we smart enough to figure it out?
Right, so that says, aren't they all secondary headaches, right? It seems like.
Right, well, but it's like, there's a cause, but it's like something about your genetics, something about your brain, something about that susceptibility, and then this other stuff on top of it. So it's a cause, but it's like not a fixable one.
You were saying that caffeine is a cause, but it can also be a cure.
Mm-hmm. It's a slippery slope.
Yes.
Yeah.
The right dose.
Yeah. Yeah. And I don't think it's very helpful to say, this is caffeine withdrawal headache, or this is medication overuse headache. You're not drinking that caffeine for no reason. You're not taking those medications for no reason. You're taking them because you had a headache to begin with. And those things are making it worse. But I try to educate patients about things that maybe they're doing that's aggravating or perpetuating, but I'm never like, stop doing that and I'll see you next year. Because again, I don't think that's particularly helpful. Okay.
Okay.
Thanks, guys.
Really, that's good.